Hello, everyone. Welcome and good afternoon from Bangladesh here. I, Dr. Shazzat Rahat Hossain, welcoming you to this session where we will be talking about health and healthcare. The current pandemic situation actually showed us exactly where are we when it comes to health. But be it about an individual, a family, or as a nation. Often we talk about bringing positive change to the healthcare seeking behavior of people. During the COVID lockdown, we realized this is not so easy, especially when you see there is no way you can go and visit a hospital unless an emergency. A number of online platforms emerged where healthcare was provided, but for obvious reasons, there were challenges faced by everyone. So, what to do now? In this summit, we are talking about no going back. But how is it really possible when it comes to healthcare? Today, we have Mr. Sajid Rahman among us, who is the co-founder and chief executive officer of Digital Healthcare Solution, which is a social business built to deliver quality, data-driven digital healthcare to millions of people in Bangladesh, and one of the largest health tech companies in Asia. It currently serves more than 6 million people, providing health consultation, health financing, and health mart. Sajid, welcome to the session.
Thank you, Dr. Sajid. It's a pleasure to be here. I'm excited to have the discussion.
Yeah, we are also very thrilled to have you with us. So if we talk about your background, you ran Standard Chartered Bank in countries of Asia and Africa. Currently, you are on the board of a bank, fintech companies, and renewable energy companies. You speak and blog on technology trends. And you have been also featured in Financial Times, Bloomberg, MWC, Fortune, World Health Congress, Royal School of Medicine, and many other events. So from this part of your background, I am very intrigued to know that why healthcare? And when you already have this awesomely established careers of yours, why healthcare? Why did you choose healthcare?
So I spent a good part of my life in financial services and banking. But when I was thinking what to do, because I sort of got a bit bored with this whole financial service area, so I thought about what to do next. I thought healthcare is probably the next frontier. And if you think of countries like Bangladesh, that's where we can really have a very long and deep impact on the lives of millions of people. The thing about healthcare is that it's a very private experience. A person who is sick, only that person goes through the journey, a personal experience, which no one actually can relate to. It's a very intimate experience. And that is where, if we have a very good healthcare service, we can really impact lives of people when they're most vulnerable. And I thought, let me give it a try and see whether I can do something in this space.
Okay, so now I think we should really talk about the platform you have built, really, digital healthcare solutions. So I see that in that platform, you are serving about a lot of things, like medical services, micro health insurance, health programs, health technology. So if firstly, let me give you a very brief about the medical services you are offering through this solution.
So we divide our services into three verticals. The first vertical we consider self as a content, where we provide health related information, how to live in a healthy, in a well-being way before a person gets sick, or even if a person is sick, how to live a better life. So it's more of a content, more of a providing the right information, because one of the big challenges in healthcare space is that there are not enough information which are medically correct. I mean, if you go to Google and search, let's say diabetes or blood pressure, you'll probably get a million, or I don't know, probably 10 million search results. But the question is that how many of those are actually, medically approved, clinically approved, suggestions. So that's one of the big areas, and especially in local language in Bangla. So that's one of the things we are trying to solve. That's the first part of it. The second part is a problem that is, that is there in every country of the world, but more so in countries like Bangladesh, where there are not enough doctors per thousand population. So World Health suggests there should be around 3. We are at 0.3. So and most of the doctors, again, are usually based in cities. So people in villages, in remote parts, don't have access to doctors whenever they need qualified doctors. So as a result, what happens is many of the people staying in city or outside city in villages usually go to the nearest maybe pharmacist who himself or herself may not be well trained. And so giving access to quality doctor consultation 24/7 is the second big piece that we are trying to solve. And here we do, many media of, whether it's the phone line, whether it's video call, whether it's messaging apps, different ways we want to do that. Also, we do different types of doctors. So one, we include specialists, we include GPs, so different types of doctor consultation. So that's the second piece. The third piece is the health financing. So, as from your experience, and we have also seen, there is hardly any health insurance in Bangladesh. So, compared to any other markets, our health insurance penetration is less than 1%. So most of the people essentially, when they get sick, they spend out of pocket. We have seen examples. I was, talking with a few of these specialists, and they were giving this example of a family where there was a person, their son had a kidney problem. So they had to start dialysis. So, they sold their savings, their whatever lands they had in the village, moved to city in a slum, and then ultimately could not continue the treatment, right? So health financing, providing that health net when a person needs it is a very big challenge and a very real problem in countries like ours. So the third part that we are trying to build is a health financing, solutions around health financing, how we can provide healthcare at a very low cost or provide the financing when they need it most. And there are many components to it. Obviously, microinsurance is a big component. Also, we have other parts like partnership with different hospitals, clinics to provide discounts on treatments, or even including Health Mart, where we try to enable people to buy things at a very low cost remotely.
Okay, so from this discussion, I was writing these things, and I have a lot of questions now. I am not really sure where to start from. So, firstly, you have said that you have a pool of doctors, of specialist doctors, and also general practitioners. I myself am a doctor, so I actually know the respected our professors whom we really think as our fathers or the backbone of this health sector. So, how but what's the challenge really to get them on board and using such technologies, because they are not really they are not used to technologies. So at this point of time, how really you actually get them on board and get them used to use this technology?
I agree. I think one of the way to see this problem is to think of technology as a way to facilitate things, not as an end, right? So the way we have to think of technology is that it is just a way for doctors to provide consultation. So the product itself, the core service doesn't change. It is an expert consultations of a very senior doctor to a patient. So that is the core service.
Yeah.
How it gets delivered is we're trying to solve, right? So the important thing of thinking of developing this sort of experience is to ensure that it is so small, so seamless, and so easy to use that it really doesn't impact significantly on a doctor who is trying to provide that service. Because what we don't want is a specialist whose every minute is very valuable to spend time on technology or things that is actually taking him or her away from the core service, right? So when we develop these technologies, we are very careful on the experience of the doctor side, so that they have a very easy onboarding experience. They can do the service just at a button of a click, or a click of a button. And also sometimes, most of the specialists will have some junior doctors helping them So we usually train them. So the whole idea is that a specialist can come in and provide the consultation the way he would have done in a normal scenario, but just virtually. So that's very critical of how we design system and design a user experience. The second thing, of course, on the specialist cases is, of course, the medical reports, right? So
Yeah.
one of the big challenges is, when we're doing video consultations, how do we ensure the reports get there? So the way we have developed our system is a person, the patient, can actually upload the reports, either themselves or someone in their family, or we have different centers where they can go and upload it. So the doctors actually get the report beforehand, or before the consultation starts. So, so the doctor can see the reports and do the consultation. So that's how we designed this doctor specialist part of it. Uh, then, then of course, there is a bigger population of general practitioners, GPs, who are,
Yeah.
MBBS or senior MBBS doctors. So there we have created a pool of doctors who actually do the consultations over audio, over videos, or over messaging app. What we have done is a system called Carrot Cake. It's a funny name that we have gave ourselves. It's developed internally by our doctors and our engineers at Coders team. So the way the Carrot Cake works is that it is like electronic medical record system. So whenever a doctor is consulting, when a person calls, when the doctor is consulting, the doctor actually takes record of the medical individual. And the next time the same person calls and maybe another doctor has picked up, the doctor can actually go to the record and see all the results of the previous discussion. So it's like a medical record of that individual at the fingertips of a doctor. And also that system has a lot of things, right? So if the doctor writes a prescription, he can click a button and the prescription goes as an SMS to the patient. So it's a very, very user-friendly system, and the whole system was developed keeping the doctor's convenience in mind, so that the consultation goes. So I agree. I mean, one of the challenges we have seen initially is we had challenges on both sides, both of the doctors and the patient side. So on the doctor side, the challenges we had is to make them comfortable using the system rather than a physical, consultation. And we had to go through that learning phase and change your system, change your process. The whole idea is that a doctor should walk in and press a button and the consultation starts.
Yeah.
So those are the things we kept in mind.
Okay. So another thing actually just came into my mind, that what about we really think about the patient doctor confidentialities and everything. So using through a platform where maybe in some cases the person who is a patient, he or she cannot really log in by himself or herself, or also from the I'm really talking about the cyber security things, because in case of video consultations, there might be some hesitation on both part, maybe the doctor part and also the patient part, that what is really going to be happening, and how the video will be recorded, will the video will be recorded and used somewhere else. So how do you face these challenges, and what really are the solution to this problem?
So it's an important point because the patient data security is very important. I mean, one is obviously the cyber security part of it, where the data doesn't get hacked, and the second is the confidentiality part of it, where the date only the people relevant have access to this data. Right? So that's where our carrot cake system has been built in a way that it has a very strong 2 layer or 3 layers of security, where a certain doctors with a certain credentials can only log in. To the extent that it is secured by VPN and other measures. We have a very strong we have a very strong coders team in our department, who actually continuously checks and ensures that those data cannot be hacked. So what we call ethical hackers. So this ethical hackers group is always checking and seeing that the system is robust enough that it cannot be hacked. At the same time, what we do is we follow a very strict data confidentiality and privacy regulations, so which may not be required as our current legislation, but we follow that, whereby we give a patient the authority to delete his or her data if she wants
Okay.
to. So we essentially try to hold ourselves to the best possible standard globally in terms of data privacy and security.
So you have no storage for the patient data, For example, if a doctor wants to see, if a patient revisits for follow-up to a doctor, so he needs to, if he deletes his previous files or data, he needs to re-upload those, maybe the previous prescription or any reports as well.
Yeah, no, so we have a storage of data in the carrot cake where a person doctor can go and check. But if a patient for some reason says that okay, I want to delete those
Okay.
data, the patient has the
Okay.
authority to ask us to do it. We haven't seen that yet because in Bangladesh, as we all know, we are not that about the patient confidentiality. But our responsibility as a provider is to ensure that we have the highest highest standard followed.
Yeah, definitely, definitely. So this is relatively, we have seen that you have already served 6 million people. That's quite a large number, if I must say, because this total solution, this total system is new to the Bangladeshi people. I'm still talking about the medical services, the consultation part, and these things. So, what is exactly the target population? Because we know that in maybe rural areas, or people are not really still not open to these technologies. They don't even have access to proper speedy internet. So, who are really your target population?
So when we designed the system, we had three things in mind. One is, of course, the convenience of use. And what we have decided is when we built the whole thing is that even if someone doesn't have an internet, but just has a telephone line, can do the consultation. So someone doesn't need to have a smartphone, just a regular feature phone, where a person dials into toll-free numbers or one of the short codes, and the person can have a consultation with the doctor. So that way, our system is equipped to do consultation anywhere in the country as long as there is a phone line. Doesn't need to have an internet. So that's part of it. In case of video consultation, that's where we need an internet or other services. That's where this internet bandwidth comes in. If I tell you, how our what sort of patients or what sort of members we see in these services. So there are three broad groups of people. One are people who are residing in urban cities like Dhaka, Chittagong, Rajshahi, Sylhet, so in the city areas, who are accessing this healthcare either through video or internet. Consumers who are buying the services for themselves or their families. So that's one group of people. The second group we are seeing where the companies are buying it for their employees. So garments factories buying it for their workers, or security guard companies providing it for all the security guards they provide to different companies, or even some cases banks buying it for their customers as part of their banking services. They package our services. So that's the second group of people. There is another third group. We partner with a lot of international agencies like UKAID, USAID, also corporates like MetLife. So what we are seeing is that a lot of these agencies are providing, are ensuring that our services goes to very marginal. So people at, let's say, at the remote parts of the country, people who don't have access to the land, maybe near a river bank or somewhere. So that is also another group of people who are accessing this service through the different, donor agencies. So we are seeing these three groups of people.
Okay, excellent. So quite a larger area you are trying to cover. That's really impressive. So what about the if someone connects to the doctor for consultation digitally through video platform? So maybe they are getting a e-prescription as well, because without a prescription here the patient cannot really buy any antibiotics or any other drugs except the OTC drugs. So what about those people you are talking about? They are using the toll-free numbers and everything. Maybe they are connecting through audio calls. So how are they really getting the prescriptions? Because the same problem comes, for example, if I prescribe someone an antibiotic, then currently, especially in urban cities, in larger pharmacies, these rules are very, very strict, and it really should be so. So they are asking that what about the prescriptions? Maybe even in some cases they are not even accepting digital prescriptions as well. So how do those people who are connecting via the toll-free numbers, they get the prescriptions?
It's the same thing. So when someone is calling from a regular phone or audio, the doctor actually takes the data, whether it's audio or video call, in the carrot cake in the system. So all the
Okay.
doctors are using the carrot cake system, and the carrot cake system sends the prescription as an SMS
Okay.
to the individual's number. One thing is very important, that every doctor, every registered doctor has a number, right? Registration number. So any prescription that goes out, it also goes with the doctor name and his registration number, as per the medical Bangladesh Medical Institute and the central body. So that sort of carry the authenticity of the doctor's name and the registration number, as well as the medicine the
So
doctor's
they
prescribed.
have that their BMDC registration number with their credentials as well as their presentation. Okay, excellent, excellent. Thank you so much for that. Because in Bangladesh, a lot of we have heard about a lot of fraud cases, especially in rural areas. They are in we have seen that original doctors they actually suffer because of those local quacks and everything, that they have such established practice that people are actually people rely on them more than a qualified doctor itself. Okay, so here, so now we are going to talk about a part which really Bangladeshi people don't like much, because Bangladeshi people want to spend for everything. They want to eat well, they want to wear good clothes, they want to spend money after those things. But when it comes to healthcare, I don't know how this idea has been established. They think that healthcare should be free. The doctor consultation should be free. But as doctors, and of course you working in this field, definitely we know that this is not a sustainable plan. So what's about the sustainability and what's about the monetization? What's your plan? How are you doing these things?
So when we first started, we had a partnership with a telco called Grameenphone, which is the largest telco in Bangladesh. So what we started doing is Grameenphone was providing the service to their high earners, or the people who use Grameenphone, services a lot. So they were using that service and was providing a sort of revenue share with us for those group of people. So the consumer end, it was free, but at the back end, we are earning as part of the revenue share from Grameenphone. But over time, what happened is we have opened up the service. So a person doesn't need to be a Grameenphone subscriber. A person can be any phone subscriber, nowadays with video, you don't even need a phone, right? You can do it over internet. So we have opened up this service for the whole population of Bangladesh. And the way we are doing it, we have different packages. So we have a package for an individual. So our packages, varies from 30 taka a month to, up to 1,000 taka a month. It varies with so in some packages, let's say a
Kind of a
person gets
subscription fee.
subscription fee, monthly subscription fee, where a person may be using, let's say in one package, the person may be getting 25 minutes of call with the doctor, plus a health insurance of 10,000 taka. And then the person pays, let's say 50 taka a month. But then if the person wants a health insurance of 100,000 taka and wants, let's say, 200 minutes of doctor's call, and wants to add 4 other family members, then it's different, right? So we have different packages, which we are seeing people buying and using it. Now, there are 2-3 behavioral changes that need to happen to really scale this, right? So first of all, one of the things that we need to remember as a health practitioner is that we don't go to see doctor every day, right? So
Yeah.
it's not, you probably watch a movie every day, or send a message every day, or call phone every day. But we don't go to see the doctors maybe once a month, maybe once in 6 months, in some cases maybe even not a year, right? So one of the big mindset thing that happens is that, okay, if I buy this package and if I don't see it for 6 months, I'm losing the money, right? So a person will probably because the price is not very high, right? So a person probably use the same amount of money buying a cigarette, a pack of cigarette or tea or whatever, right? But doesn't want to pay that for buying a health package where the health insurance kicks in when a person needs to
Yeah.
visit obviously are hospitalized. So what we are trying to do is encourage people to buy these packages and try to find a way to give the money back so that the value is added. So one of the things we have started doing is to provide discounts on certain medicines and certain things that a person buys on a regular basis. So let's say someone buys a package of 100 taka, and the person gets discount on certain regular medicines. Like if a heart patient or a kidney patient or a diabetic patient buys a certain group of medicines every month, so we try to provide discounts on those medicines. So even if someone buys it, and they might be using that money on some other medicines, and through discount they actually recover the money they are spending on subscription. So that's one thing which is helping us, people, encouraging people to get more and using the service more or buying the package more. The other thing, of course, is the whole education part of it. So the whole idea that if for some reason a person does get admitted in a hospital, then we cover a significant amount. So for example, if a person is paying 50 taka a month, in an annual basis, the person is paying 600 taka. But one hospitalization, we are providing up to 10,000 taka coverage, right? So that's far more than the person would be spending. So the idea of educating people that the insurance may not happen, and it's good that it doesn't happen. But if for some reason it happens, the financial benefit of having a health insurance far outweighs the cost of buying it. So there's a lot of education awareness also going on around that.
Okay, so that's very important, and that's actually the most tricky part, to change people's behavior, change people's mindset in this case, you know. So moving on, I am actually willing to talk about the health programs you have been doing through these digital healthcare solutions. So the technology part, we have understood a part of it. Maybe the time is not very sufficient to go through that, but I think definitely the viewers who are watching and enjoying this discussion, they have an idea. And of course, I'm requesting everyone for asking your questions if you have any, and of course we will share that with our guest today. So about the health programs, those are those are also probably about the development side. In the development side, not really a money making or any business side. Am I right or not?
Yeah, so obviously those are again aimed to be self-sustainable. So the way those development programs work, some are completely given free to the end consumers, but funded by the different donor agencies. So that's one.
Okay.
But also, one of the things we are trying to also work with donor agencies, that as they roll out these services, at the end of the day, at some point, the donor will stop funding. So
Yes.
how do we continue that service at that stage, right? So the whole idea of some of the way these whole programs are planned or designed is that ultimately it becomes self-sustainable. So we actually work three types of programs that we have been doing recently. So one type of program is given completely free. So for example, during this COVID time, with Concern International and UK Aid, we set up a sample collection booth at a place called Mugda Hospital. And we, with our partners, we set up that booth, and then we started collecting samples. So that whole testing was provided free at the consumer end, but was essentially funded by the donor agencies. So that's one. So the funding was done both by donor agencies and the GTT, so Grameen Telecom Trust. So that's one part of the program. While on the COVID, what we did is the IEDCR helpline, which is the sort of the central helpline for all COVID-related queries. So we started, managing it a couple of months back ourselves and USAID along with John Hopkins. So that's the other part of it, where we're providing the service, but funded by by different agencies. The other group of things that we try to do is, again, with USAID, we are working on providing some sort of services to garments industry. So essentially providing the video booths and others, so a garment worker can actually have a consultation from those booths. So that again is funded by USAID and those sort of agencies. There is another program where we are going into the remote part of the country, where like what we call chore areas, so very remote areas where we are providing those services free, again funded by different agencies. The other program that we are seeing is essentially corporate. So corporates like MetLife, so they have around 1 million premium holders of their insurance products. So they are also packaging these services. They are funding it from their side, but they're packaging this service and giving it free to their premium holders. So these are the different types of programs that are underway.
Okay, so uh, you have talked about the sample collection booth at Mugda Hospital. So that was an walk-in sample collection booth or home collection?
Walking.
Walk-in. Okay. So anyone could walk in to the center and get the give the samples to get tested. Okay, excellent. So I remember you were talking about a story about someone about his son kidney problems and that also relating that story with that out of pocket expenditure as well. So you have talked about the health packages. So those packages are for individuals or families or both?
Both. So we have both options. So it can be for individual or the family, depending on whichever package one subscribes to.
Okay, okay, so excellent. So now moving on, that I'm gonna be asking about a hypothetical question now. So if we in Bangladesh, it's about 160 million people, and everyone is saying that the health problems or health programs, the hospitals, they are actually urban oriented than rural. But if we go into the rural side, we can see that the structure, the system is more structured in the rural areas than the urban areas. There are the community clinics, there are the Upajala health complexes, and so the tire is actually set. You know where to go, then the referral system works. uh, the structures are at least there. So when you come to the urban areas, there is no structure really. The whole system is scattered here. Everyone is trying to do something maybe on their own or maybe from an organization perspective. So in overall aspect, we can see that the solutions, the actually the services don't really reach to the people. So we can see that there is a huge gap between the demand and the availability of the services. So what do you think that how can we really reduce this gap between the demand and availability of services, especially in urban areas?
So this is a problem which happens. So even there was some data in China where they showed that in 60% of cases, people go to a hospital or a clinic. Either they don't need to go there or they go to the wrong one.
Yeah, yeah.
So the whole idea of that study was that if we can intervene before through services like ours, where actually a person calls over phone or video calls, then the person actually talks with a doctor and does not need to end up in a hospital or clinic. So the hospital or clinics then empty up their resources to actually serve the patients who really need that, right? So the first way to solve the whole capacity issue is to ensure that the existing capacity is used to treat the right group of people who actually need it, and not scattered among people who some of them need it and some of them don't, right? So that's where I think digital health or the remote consultation can step in and play a big role in managing that traffic to different clinics and hospitals. The second thing I think we should do, which we don't have it, the point you're making about the rural versus urban. So one of the challenges in case of rural, well, they have, where there's a structured system, there is no option for advanced treatment, right? So whenever a person needs a heart surgery or some problem, the person needs to come to a hospital in cities to do those things, right? So again, on the urban side, what we don't have is what some countries have is called GP system, right? So you go to GPs. A GP is the first port of call, and they are the one who essentially then refers the patient to a specialist or to tertiary care. So there is a bit of so there's a sort of like a gate to decide who goes where, right? So we don't have it. We don't have that medical system in Bangladesh. So I think that's where we can actually connect this two and improve it. So the way I see it is, the way the digital healthcare or the remote consultations can come in. One is obviously help that traffic from rural to urban. So it's which patients needs to go to urban and then manage that. And then again, within the urban context, they can decide who goes where and what sort of treatment, what is the ideal treatment. And that way they actually manage the best treatment to the, to the most deserving patient. So that's where I think we can solve that problem to somewhat, but it's a huge system, system redesign thing that needs to happen to actually make it work. The other thing about this whole remote consultation, which I think is quite important to make it really relevant in the system, is the remote data collection. So at the end of the day, we are, one of the big drawback of remote consultation is that, so for example, doctor is not getting the patient pulse or, not measuring the blood pressure, right? That the doctor is somewhat dependent on others to do it, or in some cases, trying to capture that remotely. So one thing we see is going to happen significantly is if we can improve those points that a person can actually get data remotely. So we have enough IoT devices, enough sophisticated IoT devices that collects those data and then upload it into the system. And the digital healthcare system or the central digital platform essentially then collect those data and connect the dots. So the idea is that is a person goes from home, from where the treatment starts and the data gets uploaded, to where the person ends up in a primary hospital in a village or in a tertiary hospital in a city. All the dots are connected, and this digital healthcare platform actually helps to flow that traffic and intervene at different points to ensure that the healthcare journey is smoothless, and also put in the financing at different points. So that is the grand vision we are working on, where we think that we can connect the online world to the offline world and ensure that the healthcare journey and the health financing at different points is a seamless process. So that's one of the things that we are planning to, we hope to build someday.
Okay, that's brilliant. That's really brilliant. That could actually work. Definitely, there will be challenges, but that could actually work. From where I can understand at this point of time. So, uh, but do you have any plans to recruit or maybe put some workers on community level to do these things? Because if you actually want to reach those marginal population, they really need that help of someone who is really technologically advanced, and maybe they can connect them to the doctors, or maybe they can bring those patients onto your solutions. And then again, they cannot maybe even come for follow-up to your platform on your own. So what are the plan there? Do you have any plans for the future that maybe you can deploy some field force for that purpose?
So we are actually working with a couple of those. So one of the things that we are trying to do is connect all the pharmacies. So essentially have the pharmacies at different points, the pharmacies that we vet and we think are, are the right partners. So we train them to collect some of those, information and data at different points across the country. Second is we have partnership with a foundation called Shakti Foundation. So they are one of the providers of different healthcare services, microcredit across the country. So we are doing some tie-ups and doing some tests with them at different points and see how this community health worker system works and can we help them. We also have a program with Grameen Kalyan. So also trying to see whether the Grameen Kalyan clinics, how can we partner with Grameen Kalyan clinics and provide those services at the remote points. And we also worked before with the community health worker program of PRAC. So the whole idea is to ensure that all the different partners who have a very wide network of community health workers across the country, rather than us replicating that model, how do we partner with them and ensure that our services go to the to the remotest part of the country, and the community health workers are equipped to provide the services.
Okay, so through this platform, people really can address their urgent healthcare problems or primary healthcare problems. Is there any plan about the emergency health problems as well? We know that this is actually tough to solve the emergency health problems with the through this digital platform. So what about that part of the healthcare? Do you have any plan?
So one of the things we do is, and when we recruit our doctors to provide the services, they're trained it in a way that whenever the consultation happens, if for some reason the doctor feels this is an emergency case, they immediately refer that patient to, to hospital. So I just give you a story. So, and there are many stories like that we hear because, we do so many consultations, right? So one of the times, one of the person called our doctor, and she was very happy, and she was really saying that because of the consultation, her grandfather actually, survived because the day before, in the middle of the night, her grandfather has a chest pain, and he was a bit adamant. He said, this chest pain happens almost regularly. It's nothing. But the
A
granddaughter actually
so-called
called.
gas problem.
Yeah. So the granddaughter actually called our doctor, hotline, the helpline, and then the doctor, when he heard about the symptoms, he said you should immediately, take him to a hospital. And even though the grandfather didn't want to, but then the family, after doctor consultation, insisted and took him to the hospital. And the attending doctor at the hospital said that they're lucky that they brought the grandfather now. If it was an hour or two late, he probably would have passed away. So so we do face, we do see these sort of consultations, many times, throughout the year. But I think so that's how we try to solve that. In terms of actually connecting those services with probably ambulance providers and other sort of emergency cares, we are exploring that, but we don't have any service yet. But I think at some stage we need to do that. One of the things that, as you know, that Grameen is building on a very large hospitals, there's a work going on. And then what we are thinking is there somewhere, so there are places where, the ambulance is equipped in such a way that the moment a patient is taken into ambulance, all the data from the ambulance is actually gets uploaded to the hospital. So by the time the ambulance reaches the hospital, the doctor in the emergency care exactly know what the problem is because they've seen all the charts and stuff. No? So the question is that can we build that level of system in Bangladesh and that quality of ambulance that we're thinking? So yeah, so I think there are many many things to do here.
And also
We
maybe
haven't,
the quality manpower as well.
yeah. So we haven't scratched the surface. There's a long way to go. Yeah.
Exactly. We have it, but still, I think I personally feel that somehow maybe by God's grace or what, I don't know really. We are really blessed. We have to admit that, especially if we take this pandemic era. Yes, the situation is not the best, but also not the worst here in Bangladesh. Thanks to God as well for that. Okay, so moving on to the next segment. As the theme of this year's summit, no going back. Uh, if you ask me, I personally think that the future of healthcare is number one, of course, the best use of technology and digitally available healthcare solutions, and number two is addressing those out-of-pocket expenditures as well. As you said yourself, that people don't really plan about those the kind of things. Maybe they have fixed budget for every aspect of their daily lives, but nothing on the health sector, and they don't really, in fact. They don't really want to think about that I might get sick and I might get to the hospital for any problem. So I once worked in this sector, micro health insurance for the poor population. I want to share one of my experience from that project. That In that project, we were giving basic indoor and outdoor facilities as well, but that also includes delivery, normal delivery, and also cesarean section delivery. So when we were trying to onboard people for this micro health insurance, for the health insurance policy, the number one challenge we faced, that no one was really eager to buy these schemes or any plans. But only interested one was if someone in the family already, maybe the women are pregnant there, or maybe there is a chronic patient like cancer or diabetes, so they are really willing to take these things because they by that time they know that these things can be very expensive. So then they really look out for the help, or be it micro health insurance or any kind of health schemes. So only those people, they got interested about these things, but the rest of the people, they were not really buying the idea, buying the plans. So we see that you have covered like 3,500 micro health micro health coverage, also paid, as your website say, I can see. So how do you really address that challenge? How do you really convince people to uh, to come to your plan, to buy a health scheme?
So I think health insurance, there are reasons why I mean, if you look globally, right? So there have been different models that have been tested. So one is a government-sponsored health insurance. So, some countries have a national health insurance scheme where, where people automatically get, included in that program, and the government funds it through different other, so some other ways from the budget and other things. So that's some of these countries do it. Even countries like US and others, it's a constant battle, right? So how much should government fund, how much should private sector fund, and all those things. So that's one. The other thing is where you don't have a very strong national health insurance, but you have very strong private sector players who provide different options who are very affordable. And the way the whole system works is that unless one has a proper health insurance, it's very difficult to get even a treatment. So that's the second one we have seen. The third one that we are seeing, and which is practiced to some extent in countries like Bangladesh, is the health program or different health programs or different treatment is subsidized. So rather than providing a national health insurance and others, the government hospitals provide the service at a subsidized rate compared to the others, and that way, there is some compensation to the healthcare costs, right? So these are the three things. Now, one of the challenges that we have seen is essentially we have seen people who are reluctant to buy health insurance for different reasons. First, there is inherent mistrust about the health insurance, right? So people have this thing. I mean, if you recall, before health insurance, Bangladesh has life insurance, right? So
Yes.
and a lot of people, didn't buy those. They thought the people selling life insurance are not, are not the most ethical people, or they had cases where that claims took months or years to get reimbursed. In case of health insurance, there's a certain mistrust. Okay, there's all these fine prints which will say that at the moment they need it, someone will come in, and so you don't get a health insurance and all this problem, right? So the first thing we try to do is make our insurance product as simple as possible. So what we are saying is that we try to take out exclusion clause as much as possible to make the exclusion clause very clear that only these cases will not be covered, but no other fine prints. Second is that try to make the reimbursement process very easy. So, so the person can actually take a photo or even go to Facebook Messenger and type the claims and stuff, and the Messenger bot, because even in Bangladesh, everyone uses Facebook. So the Messenger bot actually ensures that the claim is, electronically goes back and the check and then get reimbursed. So, the whole thing is very seamless. So we try to first solve those experience issues in terms of the claim, in terms of the product feature and everything. So that's one side of it. The second thing we have tried is to ensure that even if a person buys a health insurance, if the money they're paying, even if they're not taking the treatment, it somehow get back to them through discounts with different pharmacy partners and others, so they don't feel like they're just giving the money and not getting anything back. So that's the second one we have built into the system. The third thing what we have found is, despite all this, there is a certain reluctant to use this health insurance package, and that's where we are using different modes of engagement, to the extent that we essentially to an extent we said, okay, we partner with some certain grocery stores and said, okay, if you have that, you get a discount on your on your whatever grocery, right? So we are trying a lot of ways to essentially encourage people to buy into this whole thing, so that the people actually understand the long-term impact of that decision. But again, I mean, it's a difficult one, because I think the inherent, the combination of a subsidized care with the inherent, mistrust about the whole insurance program, everything has been built over time. So, so to again, bring back that mentality is a difficult one, but I think we have made very good progress on that. One thing which I always get asked by large insurance companies globally is that how can we even do this thing at such cost, at such a price level? Because when they say, oh, you're exactly giving, I mean, 50 taka is less than almost 50 cents, right? Less than 50, around 50 cents. So you're giving a 50 cents package where you're providing 15 minutes of doctor consultation with a health insurance coverage of like $150. I mean, they can't, how does it even commercially make sense, right? So the way to look at it is, rather than looking at an individual health insurance, look at it like a public health, because we have 5-6 million people under this program. So so it's like a public health insurance where we use a probability model of the number of claims compared to the premium paid. And when we talking about not 100, not 1,000, but hundreds of thousands or millions of people, then it starts making sense. And also the idea that we have taken a lot of middlemen out and make it digitally seamless, so we don't spend time on processing, we don't spend money on claim reimbursement, right? So all these are digitally done through wallets and stuff. So that actually has brought down the cost a lot. So it's a mix of all these changes that is slowly pushing the paper.
So how's the reaction from the people? Yes, the number is very excellent. I can say that 6 million people have already been benefited from your micro health insurances. Firstly, how are the reactions? Are they willing to continue these services after the scheme ends, after the period ends? Number one. And number two, how which sort of schemes, plans, I'm pretty sure you have different plans. Maybe you pay this amount of taka, you get this, and you can, if you pay more, you can these services will be added to that basic plans. So how are the reactions, and what is the target population who are really buying those things?
Yeah, so the reactions are, of course, the people who are getting the money when they go and claim, because not everyone is claiming, right? So that's the whole, because you only can claim when you actually end up in a hospital and stuff. But the people who are ending up in a hospital and claiming, they're really, I mean, we have seen many cases where, there was one case of an individual who actually were hospitalized, did this during Eid time, and he was essentially, because he gets sick quite often, and he used to borrow money from his, families and stuff. And this was during Eid time, and because he said this is the first time he can actually buy something for his family because of this health insurance. Because the insurance took cover of his medical costs, right? So we have many cases like that where people actually got a lot of benefit because they're part of this scheme. So obviously, they are very happy, and they keep talking about it to their friends and to their relatives. So that's one. In terms of packages, what we are seeing is, so the other thing we do is called NPS, Net Promoter Score, which is essentially a way of measuring how good the service is to the people, right? So for example, Apple does, or all these companies do a Net Promoter Score. So what we found is our Net Promoter Score of a doctor consultation or insurance is very high, i.e. more people are mentioning it to their friends as a referral. So that sort of indicates that it's well accepted. In terms of the packages, we are seeing one package where it is where there is unlimited consultation. So what we're seeing is that if you buy this package, you have unlimited consultation for a year, as many minutes, let's say 600 minutes or whatever, but unlimited. And then you have a certain insurance amount. So that we are seeing is getting popular, because I think what people are finding is, sometimes people worry that, oh, if it's 10 minutes, what happens if I need 20 minutes of consultation? So the moment we say, okay, there is no time limit, then I think people get more, more comfortable of, setting them. The other thing which probably is important to mention is how are we, selling this? So one of the things we do is what we call is prepaid card. So in Bangladesh, this whole prepaid, card for phone bill is very common, right? People put in this airtime through a scratch card. So we were the first one to launch that scratch card for healthcare services. So people buy this, this scratch cards from shops and others, and then this activated through USSD system or some other telephone system and get enrolled into the healthcare package. So that way, we are seeing this these packages are getting used and bought all over the all over the country.
Okay.
Another one thing, another last thing
Yeah, sure,
is,
sure, sure.
the point you're making about how many of renews. So what we found is, let's say we first used to sell 1 month package. Then we found that, if a person is buying 1 month, it's very unlikely the person needs to use that in a month. And
Yes.
then the person
Yes.
say, oh, I didn't need that. Why should I buy next month, right? So what
Yes.
we have done is now we have changed it and start selling 6 months to 1 year packages. So we are saying, rather than buying 1 month, you buy a 6 month package or 1 year package. And then, you get all these benefits. And that we are now seeing a much more, because within 6 months or 1 year, the person uses the services and then the person gets, understand the importance of the service and start renewing it. Whenever we have seen person using our healthcare service, i.e. consultation with a doctor or insurance, the renewal rate is very high.
Okay. Okay. So that 6 months or 1 month, 1 year package, that's a single time payment, right?
Yeah, yeah,
Yeah, single time
yeah.
payment. So they don't have to pay again and again throughout the 6 months. And anyone who is watching this session, please help to do this health insurance and experience what's the positive about these things. So we have a question, definitely. So I want to go there. Yes, we were discussing about these things, but Ribu asked this question: is redesigning the health insurance service bringing remarkable positive responses from your potential customers?
Yeah, I think so. So it's obviously we think the acceptability of our product is very high. The services we're putting on the health insurance side, because like you were saying, I mean, health insurance has never been popular. Most of the companies really struggle to get the health insurance to even to thousands of people. So to compare that context, we have millions of people not doing it. So I think that is a mix of the redesign of the process, redesign of the product feature, the simplicity of pricing, and the way the whole thing is reimbursed. So yeah, so those we believe has helped a lot in making the health insurance popular among the target groups.
Okay, so then there is a common idea about the health insurance that you were saying that in case of them where when it was a monthly subscription type, monthly scheme, so people were thinking that why I am paying, I'm not getting sick, I'm paying for someone else's treatment. The project I was talking about, I worked on, I faced this problem. So after some time, they used to, I don't need it anymore. Then the idea is they think that if you can't, if there is an older people in the household, in the family, they think that he has diabetes or hypertension or heart disease or maybe even cancer. So most of the health scheme policies, they don't really cover the pre-existing conditions. So as this concept is still new to Bangladeshi people, there is of course a trust building issue. So people, for example, if I'm the son, I am more worried about my parents' disease, maybe the blood pressure thing or maybe the heart things, rather than thinking about my own future, that I might be also a patient of these diseases. But most of the policies don't really cover those pre-existing conditions. So how do you really battle it out? And if you have any schemes that also covers the pre-existing conditions, if any, so how does those work? How do those work?
So we have we experimented with a couple of options. So, so we launched a product specifically for diabetic patients, where there was a health financing part of it. But as many of the insurance would not cover diabetic, as a pre-existing condition stuff.
Yes.
So, but we worked with the companies to specifically design one for the diabetic patients. In terms of pre-existing, what we are trying to do is, I mean, one of the challenges is around pregnancy. So that's one of the reasons, many of the insurance companies don't want to do it, but we also tried to convince and launched a product in that space, especially, for ready-made garments, RMG workers and stuff. So we thought, that's an important feature that we should have. In terms of, cancer or others, so what we try to do is whenever so it's a bit of from an insurance company, wearing their hat, they obviously are looking at their cost and benefit, and if the cost of providing the service is much more than the premium they're earning, they'll obviously stop it, right? So we need to make it sustainable for them. And one of the things that we try to tell the insurance companies is that given the volume that we're talking about, because we are not talking about one or 10, we are talking about hundreds of thousands of millions. So on the ultimate cost benefit analysis, they will ultimately turn out to be a sustainable offering. So that's where we work with them. So we have different packages. Some offers very few pre-existing clause, exclusions. So they cover more. Some do, yes, some do not. So it's a mix of that. But it's again, so one of the challenges we have seen is the underwriting capability in the insurance company. So we do not have enough underwriting insurance experience to cover such a large scale of population. So one example is COVID. So when COVID happened, we were the first one to launch a COVID insurance. So and it was a very interesting discussion with insurance companies. So they were very confused, okay, what to do. Then we told them that, look, this is how we can do it. These are the possibility. I mean, at that time people were worried, right? So because they don't know how many people will get infected, and
Yeah.
if let's say if they say, okay, if 100,000 people take the insurance and 50% gets infected, then what do they do? So anyway, so we had to go through the whole process just to give you an idea. So we had to go through that. Took them through, and then it became very popular that other insurance companies started launching it, including MetLife came in and said, okay, let's do it with you guys and stuff. So we're the first to do that sort of innovative insurance products in the market.
Okay, so that's really interesting to know. And um, now, till now, we were talking about the patients. I am actually having a great time discussing about this micro health insurance, and because as I said, that I personally think this is the future of healthcare, and this should be the future of healthcare, because our lives are not getting any cheaper. The expenses are going up and up, and you can't really wait and watch, wait and see, and you can't really predict, or you can't really save money when you will be sick, because if you really get sick, if God forbid, if you go to the ICU or even more, maybe no savings is enough to save your life. So I see this as the future, and this should be the future. So in terms of, yes, the I understand that the insurance companies, they want to invest their time and they want to invest their money more on this field. But what were the challenges to get them on board about the pre-existing conditions? As you said that you have scheme for maybe the diabetic patients or others. So what are the challenges? Because there are some companies definitely, they think that this could be a lost project for them, because there is a 100% sure diagnosed people in a family, so they will use that insurance policy, and they have to pay that money. So from the financial perspective, they are not really they don't really want to do these pre-existing conditions. So how do you guys really onboard them and make them understand that this is the reality, and this should be the policy to make Bangladeshi people understand about the importance of the insurance thing?
Yeah, no, I think that it's a very valid, and we can understand the concern from insurance companies. I mean, they are into a business where they have to survive, right? So I think the way to do it is essentially, a couple of things. One is, of course, what we call, and we had this from the very beginning as we started rolling out this whole digital health insurance products, because we do very small premium compared to premium, very high coverage and everything. So we have always told insurance companies, even with this COVID and everything, please try out with a small, as a project, rather than making it your core insurance product. Let's try, let's launch this project for 100,000 people and see how it goes. So what is the claim rate? What is how actually the PNL shapes up, right? So that's the way to do this. And I have seen, insurance companies, what they have is a concept of sandbox, where they try these different types of products and see which one actually makes sense. Because one of the big challenges in Bangladesh, because health insurance is not widely available, there's not enough underwriting data to understand which product will be benefited or not, right? So,
Yeah.
so that's one of the things that we try these health insurance companies and tell them, look, even if you do this, even if it ultimately ends up being a loss, you get enough data to make your product better next time. So there's a lot of negotiations and hand-holding and the discussion of the insurance companies and their underwriters on these areas to help them do it. So yeah, but that's the way to do it. The other things that we have always told our insurance partners is that, look, I mean, this is not about one or two or 10. When we're talking a large enough population, it will make sense because,
Yeah.
initially, if you're only 10 or 100, yes, I can understand the claim and everything. But when you're talking about a million people, the claim can never be as high as the premium you're getting because, you're covering such a large population. So that's the other way, to approach this problem.
Okay. So now moving back to your digital healthcare solutions. Uh, in in terms of the implementation process, definitely this is a new thing, new idea, especially in our society. So people are not really still used to these solutions. And what is your plan going forward? And how do you really uh, get all the people, all the stakeholders, the doctors, maybe the lab partners, maybe the pharmacists, and of course the patients on the same platform?
So so we do not believe that this is a so one single company or one single institute can actually solve this problem. So this is a huge problem, which is so wide and so diverse, and there's so many stakeholders, right? So
Yeah.
so from the labs to pharmacies to hospitals, their primary care, the nurses, the doctors, the patients, the government regulators. So it's a huge problem, right? So many stakeholders. So we need to actually work together with everyone to essentially ensure that the platform and every stakeholder comes together to do it. And we are very open to partners. So that's one of the reason we partner with many startups who actually work in these fields to provide them as part. So there are some services which we don't develop on our own, but we plug in that startup or that new company as part of the service offering, where we provide them the patient to provide those services, right? So that's one. The other side of it is obviously working with all the hospitals and clinics and everything to partner with them on different areas. The other side of it is obviously working with government regulators, the health ministries and other DGHS to bring them into to provide the service. So it's sort of a joint effort, and I think over time it will take shape. I mean, we are very early days. We don't see that happening overnight, but I think at the end of the day, people will start realizing that it is not at the expense of other, but it's all coming together to improve the overall healthcare situation. So I think that way everyone will improve and will participate. But that is something which we are really trying to do through different involvements, community involvements, through stakeholder involvements and others.
Okay. Okay. So when we were talking about the stakeholders, there will be another issue arising about unemployment. It's already a big problem in Bangladesh, because if you ask me, I have worked in a tertiary a hospital, a public one. So when a patient comes, then someone from the hospital, fourth class employee, he comes with a trolley. Then he pushes the trolley to the emergency. Then he pushes the trolley to the ward if the patients need to get admitted. Then after that, the doctor writes the on duty things, on admission things, and the nurses really come then, and they push the salines, maybe if any suppository needed, once again some word boy or something like those, they come. So when people will be used to these digital solutions, of course it takes all the pain away from the patients, but it gives new pains to this these people. They suddenly will become jobless, because the less people will come to the hospitals, they will earn less because there, in Bangladesh there is always a tip system, and they really this is not a tip system. In some cases, unfortunately, this is getting mandatory. That those people, if you don't pay me, I won't give you the trolley. But it is actually open for everyone. So there is also a syndicate. So there is another issue here. So if you talk about the stakeholders, they are also an important part of the system. So how do you address those people? And these maybe there will be a new problem emerging about their unemployment as well. So what will be your strategies to get those people on board as well?
Let me first start with the doctor thing, right? So, one of the things that when we started, there was this thinking that, oh, if digital healthcare becomes big, then doctors will not have enough patient on their chambers and stuff like that, right? So that's the first thing we had to encounter, right? So, and then we started explaining to that. In fact, what we are now seeing is two trends. So, all the doctors that work with us. So we have, let's say, around 150 or so doctors, or around 200 or so doctors through different, arrangements. So most of these doctors, the doctors are also working in clinics or hospitals. And they're also, so they all, because our service is 24 hours, 7 days a week. So there are 2, 3 shifts, right? So doctors are working one shift with us, and the rest of the time they're working in the hospitals or clinics. So it's not actually taking the doctors away from their core jobs or whatever, but they are actually earning additional because, they're using the time to service other patients. So it's actually becoming a supplementary income for the doctors. The other thing that we have not started to that extent, but we are actively exploring is, if you look at the women in medical colleges, I don't have the exact data, but let's say it's 35, 40%, or maybe 30%. But if you look at the women in actually practicing medicine, it's probably less than 10%, right? So
Yeah.
we have a lot of women who are equally qualified, a doctor, but for different reasons, for family reasons or different reasons, cannot actually practice medicine. All the
Yes,
years and
right.
money they spend on getting the degree, they can't do it. Right? So through digital health, now, because one of the things that COVID forced us to do is to ensure that the whole thing is decentralized. What
Yes.
used to happen is all the doctors came to our office, and we had a huge, health center or call center where doctors used to provide services. Now with this COVID, we have made the system completely decentralized, where a doctor can actually provide consultation from his or her home or clinics or wherever she's based now. So with this decentralized system, we can actually bring all these women who are qualified doctors but not practicing into the healthcare system, so that they can actually provide consultations whenever they have. Let's say they decide, okay, every day for 3 hours, they provide consultation from their home, right? So they'd actually bring in more doctors and solve one of the first problems or basic problems we have, where there's not enough doctor compared to the number of patients, right? So I think we will create more employment for the doctors and others. In terms of the other, providers and other people, part of the whole hospital system, I think, I don't think, if it would be ideal if it actually reduces the patient flow to the hospital, but I don't think it's going to, because what will actually happen then is we'll have patients who are going to the hospital who are actually more needed to support those hospitals, and everyone can actually help them better. So I don't see anytime soon it will be like, because of the digital healthcare, people will stop going to hospital, because we are mostly focused on the primary. We still don't do anything on tertiary or secondary. So any cases that we think should go to hospital, we actually actively refer to them. Yeah.
Okay, so that is a quite a big problem. But of
Yeah.
course, with such huge population in our country,
Yeah.
that challenge is not a near challenge. I was talking about
Yeah.
definitely, but I think we should really think about those people as well. And it's good to know that you are exploring about the solutions. So at this point of time, I will be taking one more question from Tanvir Tanvir Mahbub. He is asking, when we talk about accessibility, does that include substandard medical facilities or quality medical facility? When
Mm.
we talk about accessibility, does that include substandard medical facilities or quality medical facility? So he is maybe asking about that. There are a lot of clinics operating locally. About their quality, no one is sure. So, but they are maybe one or two of them actually have some celebrity consultants as well. So, so what
So
do you?
yeah, so I think the way we are looking at accessibility is, so and we agree that one of the big challenges for for a person in a village trying to get access to a healthcare is essentially a pharmacist who is not really even a metric pass or anything, So the whole idea of us providing digital service is to essentially enable that person in the remote part of the country to get a consultation from one of the specialist doctors or one of the doctors who passed from the Dhaka Medical College or one of the top colleges, graduated, and then providing consultations, right? So that's what we bring in, access to very quality doctors and consultations that comes with it. In fact, I'll just give you another statistics which might be interesting. Uh, I I think one of the data that showed that the time spent per patient in Bangladesh by a doctor is at around 20 seconds, 20, 25 seconds, or something like that. So what we have found is when our doctors are consulting, it initially started with 3.5 minutes and it's slowly going up. So as we see the data, we are seeing the patient are spending 4.5, 5, 6 minutes with our doctors per consultation. Because probably the patient is finding that they are getting more value out of the consultations. Doctors are also spending more time because they don't have that pressure to do a consultation, go to the next, go to the next, go to the next.
That
So
queue
so
management
I
thing.
yeah, human. So I think what is ultimately happening is by bringing this technology and connecting this doctor pool with the patients, what we're doing is we are not only ensuring quality, but we're also ensuring that the doctors have enough time to consult doctors. So it's actually win-win from both sides. And if you look at it, I mean, if to do a consultation in even with a GP in Bangladesh would be let alone the cost of going up and back, and then the time spent, it will be around 150, 200 taka, or maybe I don't know, maybe 250 taka per consultations. Whereas in our case, a person is getting up 10, 15, 20-minute consultations along with health insurance at 50 taka, right? So.
Okay, so we will be taking another question. Um, Digital hospital only have cashback on hospitalization. Do you have any plan to provide cashback on diagnostic services too?
Yeah, we actually have one. We launched one where for some reason we didn't find it to be very. It was not used highly. We were very surprised. We thought if hospitalization is obviously, but we thought if we do outdoor reimbursement, i.e. someone meeting a doctor or a lab test and stuff, we thought it would be used very highly. But we saw the usage is so low that the insurance company then came back and said it doesn't make sense to continue this. We were actually a bit surprised with that particular response from patients in general. But of course, that's something we always look for, and we are trying to find out why it didn't happen. Is it a more of awareness issue from our side that we could not aware people enough, or was it the process issue where the reimbursement process took too long for, let's say, a 200 taka or 300 taka reimbursement? So that's what we are trying to solve before launching that product again.
Okay. So at this point, I want to discuss about another thing that um, from our childhood, when we were beginning to use the computers, our parents usually said that don't sit in front of the screen all day and everything. Your eyes will be bad. You will be blind someday. Uh, so but when we look into the future, technology is the future. The doctor consultation we are talking about, this is through video calls. So once again, more screen time. More screen. So how do you really think that we can change about the mindset of the people using computers or using healthcare solutions through these digital platforms, and about their those adverse effect, if they have any on health using these devices?
I think there are two things, right? So one is, I think the using the device for consultation, whether it's 5 minutes or 10 minutes, is not it's not a point of concern. The concern is more for kids or young people spending hours in social media or playing video games, right? So I think that's where the most of the concern comes from, and yeah, I mean, I guess that's something which it's a force that we cannot ignore. It's happening, and more younger people will spend more and more time. Even nowadays, what's happening with all this COVID-19, the education has moved digital, right? So people are doing their courses digitally and spending more time. So I don't think we can take away from it. But my thinking is that as long as the time spent on screen is productive and actually helping some way, then I think it should be okay. In terms of the health aspect of it, I think, I mean, on the aspect of impact on eyes and stuff, I think if it is not a very prolonged use of hours and hours, if it is a break, it should be okay scientifically. But then, of course, the whole idea that one should, what is the negative side of it is not to do physical exercises. The young kids and stuff, they spend so much time on screen. They don't spend time on physical exercises, which is probably a bigger concern. And some
Yeah.
other, we really need to push people to go more physically active and try to do things, not to spend all time in front of screens.
Okay, so have you do you have any system or any, maybe if someone subscribe to any of the plans you have, do you have any system to send them SMSs maybe, or maybe some other means to promote healthcare, and how people do really respond to those?
So in general, we are very careful because we used to send a lot of SMS, which was not taken, so the feedback was not good. It was negative because people don't like to get, all these SMSs. So we are now very careful. So when a person subscribes, obviously there's a SMS which goes out mentioning that the person has subscribed to this package. These are the benefits. So that's there. But in terms of pushing content on SMS, we used to do it a lot, but now we have reduced it significantly because we have found the experience or the feedback we're getting was not good. So we are looking at how to do it better. I mean, one thing obviously we do is through our app. We have an app which does a lot of content. So it is not, anyone who goes to the app can read the content whenever they need it, or or maybe read about in web page and stuff like that. But we are thinking how to use SMS more in a better way, in a prudent way, so it does not create annoyance, but at the same time deliver messages. So it's a fine balance between the two, and we have to still get the right mix.
Definitely. And so we are nearing the end of this session. And thank you so much, Sajid, once again for this awesome conversation. I thoroughly enjoyed it, and I hope you enjoyed that as well. And thank you to our viewers as well, who really watched this session, asked questions. So Sajid, on closing remarks, what do you think where Bangladesh is going regarding healthcare? What is the future, and how we all can contribute on a positive note? Maybe sharing the ground under the same umbrella.
So I think the healthcare journey that Bangladesh went through cannot be undermined. I mean, if you look at the most of the human development indexes, in terms of reducing child mortality, reducing death during pregnancy and stuff, we have or the human longevity. So we have significantly improved in most of these metrics. But I think those are the basics one. But we have a very big problem, a tide that is coming towards that direction. It is the impact of all the non-communicable diseases, heart, cancer, diabetes. These are going to be much more significant on an individual at a health level and a financial level. And I think this is a tsunami that is coming to us because of the mix of our lifestyle, our food habit, of different things. And that's where I think my request to everyone listening to this is sort of like a call, and also in line with the no going back theme, is that we really need to rethink how we approach healthcare, use technology, use the partnership, use the knowledge base that we have among all these stakeholders to actually ensure that we significantly improve the discussion around healthcare and improve the solutions that we are providing to the people, to work as a team, to rewrite the healthcare journey and process as we build it from scratch. Because the impact of all these diseases, and we know people within our relations with friends or families who are suffering from all these diseases, and we are seeing cases of these diseases coming younger and younger population, right? So cases of heart problem, cancer problem, high blood pressure, more and more younger people are getting impacted. So we really need to wake up and solve those problems. It's high time we start acting.
Thank you so much, Sajid, for connecting with us. And we hope we will be doing this conversation in person as soon as the world gets better, definitely.
Thank you. Thank you. Thank you. Thank you, Dr. Shazzat.
Thank you.
Thank you.
So that was it from us from this session. And as we were saying that Mr. Sajid Rahman was with us. He was the co-founder. He is the co-founder and chief executive officer of Digital Healthcare Solutions. And as we were talking about these digital solutions throughout this period of time in this conversation, that if we look about the future, into the future, we need to use technology. We need to integrate technology with healthcare solutions, and we need to be we need to be adaptive, definitely, because you cannot really plan about a pandemic. You cannot really plan about life. You can plan a lot of things, but you cannot be sure about them. So be ready, be healthy, take care of yourself, and of course, be thankful to God that we are still alive. Thank you so much.
Thank you. Thanks. It was a pleasure. Thank you.